It's 6 o'clock now, so I'll go ahead and kind of get things started. So we were just talking a little bit of logistics, so hopefully everybody can hear us and see us okay. We've done a few of these, which is great. And so what we've done in the past is I've just done a quick little introduction, which I'll do in a second, and then I'll hand things over to Lisa and to Anthony to do their little presentation. As people have questions or comments, there's two different ways. You can enter things into the chat box, or there's a Q&A function, which I can either put answers in or we can answer them online. So please feel free to use either one of those and I'll monitor both of them. And then if you have questions, we can, Susan Cups and panelists are saying, Dr. Napoli, looks like you're on vacation. That's funny. Yeah. So even good comments like that, we'll be sure to pop them in. I'd like to make it as interactive as possible. I sort of think of it as a talk show. If it wasn't for COVID, we'd all be sitting around sipping little coffee drinks and chatting around a desk or something. But I'm really looking forward to the presentation. We've had some great turnout with the first presentation we had for infectious disease with COVID and the flu with Gail Jackson and Francine Tuzard-Romo. And then Dr. Kamal and Dr. Fields did a little dynamic duo on inpatient rehab, which was great. And then Dr. Mason did a little presentation with Jen Pendergraft on the total joint program at Newport. And he had a few patient testimonials, and that was another great event. So looks like we're already closing in on 30 or so people, and we'll probably get a few more as they come on. So we'll go ahead and get things started. My name is Jeff Gaines. For those of you that I don't know, I'm the Chief Medical Officer at Newport Hospital and an emergency physician by training. Had the pleasure to work with Dr. Napoli in the emergency department and work with Lisa as well and the rest of the ER team. And so really excited to have them on to give us a little idea of what things are like at the tip of the sword in the emergency department, especially during this pandemic. So Lisa, you and I, we know each other pretty well. You've been the director of emergency services in the ER for the whole time I've been there, so over 10 years. You just recently added respiratory therapy to your panel of activities that you oversee at the hospital.
Right during a pandemic, it was great.
Yeah, perfect time to pick up respiratory therapy, right? So thank you for overseeing that important function and keeping all of our patients breathing. That's, in my opinion, is really a core value of Newport Hospital, is all of our patients continue to breathe and breathe well. So thanks for helping them do that. I learned just while we were going through bios that you're a mom of two, and I didn't know both of your daughters are dietitians, so that's interesting. Yeah. So maybe we'll get some good lifestyle advice and diet advice from you.
Yeah.
And I did know that you were born and raised in Middletown, and so you are not only a Rhode Islander, but you are a true Islander. And so you certainly represent the community of Newport and the Newport County, Middletown, Portsmouth area. And so thank you for being part of this your entire life and for giving back so much to the community the way that you do. And also doing your teaching and your instruction at URI. I know you've mentored and taught many, many nurses there as well as in the emergency department. So just a huge thank you on the behalf of Newport Hospital and the whole community for all the service that you provide.
Thank you.
And then your sort of dyad partner in the nurse physician dyad is Dr. Napoli, who I also have known for a really long time. Obviously, I know you because you and my wife both went to Georgetown Medical School. So we kind of met even way back at that point. But you've been the chair of emergency medicine for a good long time and obviously been the medical director for our emergency department here at Newport Hospital. And so you were my boss when I worked in the ER. And so I always tried to behave myself. Hopefully I did a good job. I know you did your residency here at Rhode Island Hospital in the Brown program, and you still do a ton of teaching. And in fact, you're an associate professor there. And I know I've sat in on many lectures and conferences and education pieces and learned some things about EKGs and things from you as well. So you've certainly taught me a lot, both on the emergency medicine side as well as on the physician leadership side, which is kind of where I find myself now. So really appreciate your mentorship and all the advice that you've given me over the years. So this is a particularly meaningful community lecture series for me, but it's not about me, it's about the community. And I really appreciate you taking the time to go through sort of what the experiences have been in the emergency department, what COVID has brought. I know you've put some things in about treatment and vaccines, so really exciting stuff. I won't take up any more time. So like I said, I will monitor the chat and the Q&A. Please feel free to put questions in either format, even during the presentations and things. And if there's a pause in the action, I can pop them in or we can chat about them at the end. So I will hand it over to Anthony and to Lisa to take it from there. And then if you have any trouble sharing your screen, I have your presentation too, if you need it.
All right. Well, thank you for the great intro, Jeff. It is a pleasure to do this. I've done this once before, I think about 2 years ago. The format obviously is a lot different today. I can't see any of you, unfortunately, and it's a lot better to do this in person, but obviously the circumstances dictate otherwise. As Jeff said, I would typically say at this point that I would prefer this be an interactive kind of discussion, and it's hard to do so without people putting things in the chat, or I don't know if Zoom has the raising the hand function or what have you, but please, Jeff, if you do see something, break in, because I'd rather this be something where when a question comes up or if there's discussion to be had, that's kind of the point of this, not for us to kind of lecture to people. With that being said, I will try and share my screen here, and away we'll go. Whoop, did that work for a second?
Yep, we're good. I can see it.
Okay.
Thanks.
All right. So I'll start off. Lisa's going to jump in, and Lisa jump in at any time, but Lisa will jump in a specific part. And again, thank you very much. Thank you to Lisa, who has been my partner in crime for, I think, 5 years now. It has been a wonderful experience. We've titled this lecture "Update from the Front Lines: A View of COVID Pandemic from the Emergency Department." And generally, we're going to kind of follow this kind of pathway for our discussion. So first things first, we're going to kind of give you the latest update on the pandemic. A lot of people who are on have probably been obviously following the news. It's helpful to have kind of a distilled version of it, I think, to distill it from the national down to the local. Then talk about what life is like in the emergency department, both for the healthcare personnel, but more importantly for those people that we serve. And then treatments available through the lifespan. And then obviously one of the hottest topics currently is vaccines. So as we work through that again, there's clearly some breakpoints, these 4 sections. There's clearly some breakpoints during the talk where when we switch directions, feel free to jump in with questions, or at any point jump in with questions. So that being said, I'll start off with the latest updates on the pandemic. What you have on the screen here is, and those of you that read the New York Times will recognize some of this, is the cases that you're seeing globally, and then the cases you're seeing nationally. On the left, you see the cases nationally, and then on the right, you see cases globally. This is basically as of the end of 2020. So I kind of screenshotted these December 31st. And much like a lot of people heard, we are in effectively surge 3. And one of the few benefits, I guess, of doing this talk online is that I can actually draw on the screen, I believe. So at times I'll draw on the screen. So we had surge 1 in April, which everybody kind of saw, and then there's sort of the surge 2, and now we're obviously in surge 3. Surge 2 in large part was kind of, at least in the US, that was kind of when we went from a surge in the Northeast, which was in April, to things kind of spreading to the Midwest, and now where we find ourselves in sort of the third kind of surge is across the country. We at one point went from, it was quite remarkable to see 100 or 1,000 cases in a day to pretty quickly escalating. I remember in November, we were talking about, it wouldn't be a surprise that by the end of November, we were seeing 200,000 cases a day. And in mid-November, we were seeing 100. And you can see clearly that escalation right here. And that's kind of classic of these surges, and particularly this last surge. We'll get into what's different a little bit about these surges in a little bit. And then just looking at it globally, they haven't followed quite the same path as we have. There hasn't been sort of quite the second phase. It's just been kind of a global rise, but certainly there's been a rise in the winter as well. If you're a fan of history and you have read about the 1918 pandemic, this is not much of a surprise. It kind of follows somewhat the 1918 pandemic, where there was an outbreak in the spring or earlier in the year, and then the fear was that it would come back and come back stronger in the fall, and that's kind of what we see here. That's classic also the fact that as people go indoors, you start to see more transmission. You see people in closer contact with each other. It's harder to do the things that we talk about for social distancing. So that's why what you kind of see, what you're seeing, at least part of it. As you look at the rise here, note obviously that there's been a couple of points you've seen people like Dr. Fauci talk about where there would be a rise around Thanksgiving and people need to stay away from group gatherings, and you need to do the same about Christmas holiday. And you actually see right around Thanksgiving a sort of a drop here. And that's two things, actually primarily one thing probably, which is that testing decreases around that time. And then people right around after the holiday go out, get sick or get tested, and then you have a repeat surge. And the concern all along has been that we are at a downspout, but we just had Christmas and that we will kind of surge back up again. And that is yet to be determined. That's obviously what people are hoping will not be the case, but fearing will be. So generally speaking, we're now at 82, 83 million cases worldwide, nearing, I think we actually hit the 20 million case mark at this point in the United States. And obviously 342,000 deaths, making what recent literature suggested COVID being the third leading cause of death in the United States last year, essentially behind the two leaders usually being cardiovascular disease and cancer. So that being said, we moved to Rhode Island, and many of you have heard, at least myself too, different sort of messages we've heard about Rhode Island. When early spring, we heard Rhode Island was once making news as being one of the examples across the country as to how to roll out a sort of disease containment, testing, what have you. And now what you see in the news is something on the right, for example, from NBC News just a couple of days ago, that these three states have the worst COVID infection rates of anywhere in the world. And obviously, California has been in the news lately, but we ourselves have been in the news as well. And we'll talk about, to some degree, why Rhode Island is one of the hardest hit. But there's a number of reasons for that. We were at one point dubiously put in the news as having the highest rate in the world. And that was for I think 1 or 2 days. But the answer is kind of complicated as to which we are. Are we doing a great job, or are we having both at the same time one of the worst outbreaks? And so the answer to that's kind of complicated. I'll touch base on that a little bit. So we have the third highest case count per capita. We also test at the highest rate per capita in the country. And so that gets at, to some degree, why you're seeing Rhode Island have such the high case count. Our president at one point said something along the lines of, if we would just stop testing, we wouldn't have, something along the lines of, we just need to stop testing. That was in the early outbreak. What one could be referring to in that circumstance is that if you're not testing, you're not finding people with COVID. And we know that most people with COVID will be either asymptomatic or mildly symptomatic. And you might argue that identifying those people because they're really not going to get sick is not an important thing. But those are the people that also go on to infect the people who eventually do get sick. So having a very robust testing program is one of the sort of standards of containment of disease. And you've seen other countries being examples of that, particularly in Southeast Asia, where they've been able to control the COVID outbreak by just having testing large swaths of the population. So we, in some ways, look like we are one of the worst. Obviously, if you look at this, we have the third highest case count per 100,000 people in the country, and that's kind of this data point right here, and that's what makes the news on the prior slide. But we also, as you can see on this next slide here, we also test at a greater rate, the green bar being the number of tests done, the yellow being the positives. And if you look at that, we test at a rate that is twice the testing rate per 100,000 residents as Florida does, for example. So we're doing far more testing, so we're finding far more people with COVID, whether it's mild, moderate, or even asymptomatic. And many of you, myself having been tested, asymptomatically tested a number of times already, know that you can go onto the Department of Health website and get yourself an appointment and get tested at this point. And pretty easily get test results probably within 12 to 18 hours back. Those sort of abilities were not there in the spring, and that was largely because just testing was not as readily available. So you've seen our Department of Health and government leadership really scale up testing, and in large part that's why, in some part I should say, that's why we are sort of scoring at the highest testing rate. If you look at some of the other places in the country that are not testing as highly, they're also just not finding as much COVID. And so if you compare those two, we currently have the third highest case rate per capita, we have the highest testing rate per capita. And so if you look at the chart on the right, this shows the positivity rate. So Alabama and Pennsylvania, for example, would look, if you look at the right side on their positivity rate, they would look quite severe compared to us. We have a 7.2% positivity rate, and this is just selecting a couple of states. But if you look at the number of tests they're doing per 100,000 residents, they are doing 1/10 of the amount of testing that we are, and their positivity rate is much higher. So they're just not testing as much people. They're testing just those people in some ways that are probably most likely to have disease, and therefore finding disease half the time when they test. But we have a much more robust testing platform, and therefore can then pair that with contact tracing and quarantines and recommendations along those lines to keep people safe and reduce the spread of COVID. So how, now bringing it down even one step further, how are we faring within the specific counties in the state? And again, you can go, for those of you that have the New York Times, particularly on the web app, you can go and look at these specific things. This is Newport specifically on the right. And you see that we had the outbreak that everybody knows about in April, where we had perhaps more severe disease. And now we're just having more cases, and obviously it's a much higher case rate at this point, where we're having probably on average about 1,000 patients per day. You'll see blips in this where on certain days it looks like it bumped up significantly, and on other days it didn't. And to some degree that's because we get data dumps, if you will. On certain days we'll have 3 days worth of data. On other days we'll get none. For example, on the Thanksgiving Christmas holiday, there's no data. But if you look at Newport and the Newport County as a whole down here, the light yellow, if you will, for example, right here is relatively speaking good. Obviously, red in here, the Providence County area is the highest outbreak, Central Falls, and there's reasons for those characteristics, and we'll get to those in a second. But the fact is that within Rhode Island, South County, Newport County are the lowest hit, and in fact the infection rates in the case counts per capita in these locales, both South County and Newport County, are anywhere from 3 to 5 times less than they are in Providence County. And so our colleagues in the other lifespan facilities at which we work, Miriam and Rhode Island Hospital, are seeing much higher rates of COVID presenting to their emergency departments and being hospitalized. So many of you have seen that the field hospitals have opened up in Cranston and in Providence. This is the Rhode Island Convention Center Field Hospital. I've actually worked here. This is where the patients, certain patients that have COVID are cared for. They're cared for by a multidisciplinary team of pediatric emergency medicine physicians, hospitalists, other physicians who in large part volunteer their time, and nursing staff from effectively throughout the state and throughout the country. All lifespan hospitals, because this third surge, as you saw earlier, is a much more prominent surge in terms of numbers, are seeing capacity at near 100%. In other words, almost all hospital beds are full. And there's a couple of reasons for that. Not only is COVID, has it spread throughout the community much more people are getting COVID, and therefore more people at risk of having bad outcomes or getting sick with COVID or coming to the hospitals, but we're also not shutting down elective care as we once did in the first outbreak, and continuing to provide care. That was a brief kind of hold, if you will, on elective care. That's not something obviously you can do for a long time. You don't want to put people at risk by not doing mammograms, not doing cardiac stress tests, not doing echoes, not doing colonoscopies, et cetera. So we had to find some way of making sure we can do both. And in large part, that kind of brief hold was the result, if you will, of not having enough tests to be able to test the people before they came in for elective procedures. And now that we do, we can go on and do both at the same time. And that kind of contributes too, as people potentially delayed their care or getting the care that they might have needed in the spring and coming to the hospital. So when I said earlier, there's some reasons also that Rhode Island is more at risk for having higher COVID case rates and higher hospitalizations than other states throughout the country. And some of those you can see here on the right of the slide. Our state has a higher risk population. We have a more elderly population, minorities. We have more minorities than certainly some states. And in the Central Falls, Pawtucket, Providence area, we have people living in more close-knit communities, multi-family households, multiple people within a family. What comes along with being elderly oftentimes is more heart or lung disease in those patient populations, elderly patients or people with heart or lung disease. Some other comorbidities like obesity and diabetes lead to people having more likelihood to have complications and coming into the hospital. And then obviously patients who are immune suppressed are also just more risk to infections in general. We have actually, as many of you may know, one of the most densely populated states in the nation. That contributes obviously to our case rate and people being in contact with each other. And some of the highest density areas, as I mentioned earlier, are also happen to be the hardest hit, and some of the socioeconomic demographics are such that it's hard to prevent people from exposure and do the contact tracing that we would need and be able to socially distance the way we would want to prevent those kind of areas of having outbreaks. So Rhode Island testing rate and hospitalizations you see here. There's increased capacity to test, increases positive tests, as I mentioned, and hospitalizations have clearly exceeded what we saw in the spring, and that's what you see on the right. So what we saw in the spring was much like what you saw in New York City, was kind of in the March-April time period, probably people getting infected, and then the disease multiplying the number of people infected, and then at some point we hit a critical mass where the people most likely to get sick started hitting the hospital, and that's what that quick acceleration is. This time around, we're seeing we're seeing more hospitalizations, but now we're not necessarily just filling ICU beds, we're filling floor beds at a greater rate than we did in the spring, and so that adds to the greater hospital capacity census being at around 100%. So again, what is the difference between the surge in the spring and the surge in this winter? I call surge 1 and surge 2 because we really didn't see anything over the summer. In fact, it was quite low. We had higher acuity patients, many of the sick ICU ventilated patients in the spring. Many of the patients that came in, as you all know, a lot of them were in nursing homes. That was before we had the ability to test, before we even knew that COVID had essentially spread throughout nursing homes in many parts in the country. And so you had more sick patient populations coming in, and therefore you had a higher percentage of patients coming in and needing ICU care. Obviously, there was some news about PPE availability being constrained. And believe it or not, one thing that I'll touch on in a second is emergency department volumes were down 50%. It's just that the patients that were there were more likely to be COVID patients. And as I mentioned before, elective visits and procedures were shut down. People were indoors. There was no sports. So that's part of the reason you saw the non-COVID illnesses that we tend to see in the emergency department, musculoskeletal trauma, things of that nature, just not coming into the emergency department. When we move to Surge 2, which is kind of where we are now, you have a higher volume of patients. A greater number of those patients are floor-level patients. We now have testing in skilled nursing facilities where people who work there get tested on a weekly basis. The patients that come in there or go out are tested before they get in, and often tested on a frequent basis while they're in the skilled nursing facility. So those people most at risk are being identified and quarantined if they are positive, but essentially preventing outbreaks in those highest risk areas before they occur. PPE for us is generally now mostly available. That's not as much a concern. ED volumes have risen closer back to our norm, though not clearly back at our norm, because we have a lot more of the other, the elective procedures, the delayed care that people might have had, and just people being out and not locked down like they once were, and therefore more emergency department visits. So this is I have two slides here, which is, I suppose there's a positive in a lot of things. And the black here is all COVID. This is when we send a swab and we test for viruses. All of these viruses here on the right are the things that someone could come in with respiratory illnesses and we can identify. So you have flu, all these things here. And then down here you have COVID. And then you have all these other things, most notably here, rhino or enterovirus, which is essentially your common cold. So what you're seeing here is basically when we send a test for someone with respiratory illness that comes into our emergency department that requires this testing, throughout this fall time period up until basically the new year, it's mostly COVID or rhinovirus. And so perhaps a silver lining of the message that you've seen throughout the summer and the fall of people wearing masks, both healthcare providers, patients in the emergency department, people outside of the hospital, is that this is one of the mildest flu seasons you've seen in years. And so this is basically 2021 compared to 2020. And so we just have not seen much influenza. And so it had the major concern all of us had was just this, that we would see not only COVID, but we would see a burst of influenza and hospitals would be truly over capacity. So perhaps some silver lining of the wearing the mask and socially distancing and those things that we can do to prevent respiratory illnesses. And then lastly, as I talk about just the general demographics and finish phase one of our kind of agenda here, this is the emergency department volumes across our lifespan hospitals. And what you can see here as far as Newport, it's this purplish color. And this is us at 100% capacity, and then everything shuts down in the spring, and you see all of our emergency departments, most notably Hasbro's volume going down significantly, and then slowly creeping up as the summer went along, and then dropping down a little bit again, but not back up to 100%. And part of the message here really is that people have this perspective that the emergency departments are bursting at the seams and that I shouldn't go, and that my, for example, my chest pain is really not a big deal, or the tingling I had in my hand, I think I can wait a couple of days to see my doctor. The emergency departments are not over capacity, and as we'll talk about in a second, the operations are different, such that the idea of avoiding the emergency department because there's a bunch of COVID there, or avoiding the emergency department because staff don't have the capacity to care for patients because it's all COVID all the time. The point here is mainly to say just that the emergency departments are at this point pretty skilled at splitting out the patients we think might have COVID versus patients that are coming in with non-COVID illnesses. And we don't want people delaying to come to the emergency department. And so that's kind of the point of this slide. Before I go on, Jeff, how are we doing with questions?
Yeah, so far we're going pretty well. I put my video back on here. So I fielded a few questions from George Petrovus about vaccines. And so we'll come to those when you go to your vaccine section, I think. And then Edna put in a question, how many beds in Newport Hospital are designated for COVID and how many are filled with COVID patients? I can take the hospital piece of it, and then you can certainly speak to how the ED is set up. But so Newport Hospital has a little over 100 beds that are operational altogether and designated for COVID. We can put COVID patients in a lot of different beds, but we have one entire floor that includes our intensive care unit. That's 21 beds, and that entire floor is all negative pressure. And we've sort of designated that as a warm zone, if you will. So patients with COVID tend to be clustered into that unit for obvious reasons. We do have a few other negative pressure rooms scattered throughout the hospital here and there. So in total, we can handle probably about 30 COVID patients at any given time in the hospital. And then we could always be careful and put them in other beds that maybe aren't negative pressure. We just have to be careful if we're doing any procedures and things on those patients. But in general, we could certainly comfortably accommodate more than that. So of the 30 beds that we could easily fill, I believe today we hit our personal best of 16 patients. In the past, we'd always sort of hovered in the single digits, but as Dr. Napoli mentioned, the numbers have been kind of climbing. So we've been in the 14, 15 range, and today we had 16. So we're at about half of the beds that we would have potentially designated for COVID, and certainly with our surge plans, we could accommodate more. Anthony, do you want to add any more about how the emergency department is kind of divided and how you handle those?
Yeah. So the emergency department, I'll pass that to Lisa. Well, actually, Lisa can talk about that, and then I'll actually show some physical diagrams of how the emergency department is divided in a second. But effectively, we've split the emergency department in half in terms of COVID and non-COVID. So basically, about half of our beds are beds that we have pre-categorized as beds that we could take care of COVID patients. Obviously, we can take care of COVID patients in any bed in the emergency department if we need to, but to some degree, we're trying to separate people out. So that answers that part of the question. And just to dovetail on what Jeff said, we're also particularly the 3 lifespan hospitals are trying to make use of the field hospital or the alternative hospital at the Rhode Island Hospital or at the Rhode Island Convention Center. It is the same personnel that work. Some, I don't know who's on right now, but I've worked there. Some of the hospitalists that work in Newport have worked there. Some of the people, the primary care physicians in the Newport County community have worked there. It's the same medical record. It's a lot of the same people. And so one of the fortunate circumstances is that when we built, when the state built the field hospital in the spring, the lease was such that we were able to still have it there when this surge came in the fall and be able to open it up. And so select patients can go there, and frankly, having been there and talking to some of the patients, have great experiences and great things to say about it. So that's another way that we're able to, as the beds fill up in respective facilities, as Jeff alluded to, are not particularly full of all of our quote unquote COVID beds in Newport Hospital, but other hospitals have been, and patients basically are moving to the what's the equivalent of an inpatient floor just at their convention center. All right.
Yeah, so thanks for bringing up the convention center. I think that's really important. And, I think just to give people a sense, our hospital has been at any given day, maybe 10% today, 15 or 16% of our patient, the volume in our hospital is COVID. Some of the hospitals in Providence that are seeing a little bit more numbers, like the Miriam Hospital in particular, maybe pushing more like 20% or so, but still, just to give people an idea, a good 3/4 or more of what we see in the hospital is the same stuff that we see even not during a pandemic and has nothing to do with COVID whatsoever. So still a big bulk of our business, both in the emergency department and throughout the whole hospital, is a good 3/4 or more is not related to COVID directly in any way.
Take it away, Lisa.
All righty. Thank you. First of all, I'd like to thank everybody for joining this Zoom. Like Dr. Napoli and Dr. Gaines mentioned, we'd much rather have a face-to-face, and that's what I'm more acclimated to, but we can all join the Hollywood squares here and try to get through this. And thank you for that great introduction. Oh, I think I had control of the screen, but it's not moving.
I got you then. It says it's waiting for you to take control of the screen, but it also says, oops, did you take control of this? All right, I took control back, I guess. So just tell me next slide.
Sorry about that.
That's all right.
So challenges in the ED, Dr. Napoli kind of spelled out the surge 1 in the spring and then surge 2 in the winter that we're experiencing right now. In a nutshell, just to start off, it's really about, for us in the spring, it was really about the unknown. We didn't have a handbook for COVID-19 pandemic. We didn't know what we were getting into. Like Dr. Gaines and Dr. Napoli mentioned, flu was going to be coming, and we thought, what are we getting into? We knew that patient and safety was a priority. Safety was a priority for patients and for staff. Testing was changing daily. Availability and quality and the protocols of all the tests was just a constant fluid motion, and staff, we're just having to make changes every day under our leadership on what to do and what not to do. A big concern was PPE. There's nothing like the fear of not having enough personal protective equipment to take care of patients that are infectious. We were very fortunate that Lifespan procured enough equipment and that we did have enough PPE. But that always remained, kind of on the back of our minds, like, will we run out as we get through this surge? As far as infection control, fear again can make somebody extremely vigilant. Not just washing hands and wearing the proper PPE, but, we had to reduce visitors. We had to emphasize screening at the front door. We had to look at, screening our own employees and making sure that everybody was in a safe zone. The department itself, as far as place, I think Dr. Napoli touched on this. At the entrance of the emergency department, we started very early on separating patients that came to the department and screening out patients with any symptoms. We put them in a different area so that if you brought in your infant with an ear infection or ear pain, you would be in a different area with somebody who had lost their taste or smell or had a fever and a cough. Again, in the spring, there was a lot of unknown. Like I said, the symptoms were added to the COVID. We started to see, sore throat, fever, cough, and so forth. So every day, every week, we made changes to our protocol of who we screened and how we separated our department into an A core and a B core, and separating the patients that might be at high risk. We call them PUIs, persons under investigation. It sounds a little formal, but it works for us. Minimizing staff exposure was really critical. Making sure the place was cleaned constantly, having enough staff, not just healthcare workers, but ESD staff and facilities. I've never counted so many things in my life. We were counting daily, ventilators, masks, circuits for machines. I was constantly asking staff, count this, count that, and they did a great job. Inventory was really critical in the spring because of the fear of running out, which thankfully didn't happen. And then medications that were onboarded for emergency use criteria was put into place, and that gave a little sense of security. Go to the next slide. Thank you. As far as personnel, being a nursing instructor, I really value having students in the department. We get respiratory nursing, EMT students, but we really had to look at risk management and kind of mitigate the risk with having people come into the department. So we had to put a stop to students coming for some time. Then elective procedures were stopped in the hospital. And like I said, it was an ever-changing situation every day in the first surge. We started this app on our phones called Slack. Anybody can download it, but there are private zones, so you can have a private team where you can share information. And this was really key for our emergency department staff because policies were changing daily. Research and news was coming out from CDC, Department of Health, and it was really hard to keep up with all the changes. One day you're wearing a paper mask and a certain gown, and then the next day they're adding goggles and cappers and pappers and all sorts of equipment that staff really had to acclimate to and get fit tested for. We started to be able to triage patients through a monitor, really adding electronics to add to the Slack app. And I kind of skipped over Zoom and Teams. We're on a Zoom now, and like I mentioned, the Hollywood Squares or the Brady Bunch team. I've never been on so many Zoom meetings in my life, but we do need to make sure that communication continues and that it's open and that it's effective and that it's two-way and it's up and down and all around. So we've made ourselves available on many Zoom and team meetings. The Lucas CPR device, in case those of you that don't know, CPR, cardiac pulmonary resuscitation, is a very high risk procedure. Unfortunately, our staff are used to doing it in the department. It's high risk because it's an aerosol generating kind of procedure. And we were very fortunate that a donor donated a Lucas device to the department. So we have that available to use. Providing care, like separating patients, like we said, we pretty much divided the department into an A core and a B core. We have a 30-bed department. We used to be a 17-bed emergency department. And we have, we don't necessarily call it warm zones, but our warm zone is pretty much the A core. So anybody presenting that could be a possible COVID will be put in a certain area of the emergency department. Really looking at who's at risk, who's not at risk, making sure there's safe discharges, safe treatment, on discharge, and making sure that patients have the resources that they need. Those are all topics that in the spring we're looking for answers. We really wanted solutions to all of this, and it's just a constant, need and resource allocation. And I think we did a really great job. And then we continue on to the winter. Next slide, please. Sorry. This here is a picture of our staff. I think I'll start on behalf of the staff. I know that they would love to, first of all, personally thank all the community members that sent food, beverages, tokens of appreciation, letters. We had schools sending adorable thank you letters to their heroes. It was really great. It was a much needed gratification, and it was really embraced by all the staff. The picture on the right, we're used to celebrating and accolades and having celebrations, having employee of the month, smiling, laughing, seeing each other. That's what it's all about. You have to really enjoy your work to do a great job, because if you're miserable at work, you can't really take great care of patients. And we have a really great team. They're an awesome team. But the picture on the left is more what you see, since February, March of last year. We see each other's eyes for the most part. We're covered in masks and headgear and all kinds of apparatus for safety. You can skip to the next one, please. Here's a few more pictures of our family, we call it our work family. There's how we used to be, taking pictures, and then the bottom ones on the left and the right are more of what we see of late, dressed up in PPE, or the personal protective equipment. But they're not just healthcare workers. I just, want to make that point out there. Oh, sorry, you can go back or stay on this slide. So they're not just healthcare workers. There's moms, there's dads. A lot of our staff are dealing with small children at home. Homeschooling has been really difficult. There are staff that are trying to train grandparents how to homeschool, how to use Zoom, how to, use the electronics. It has not been easy for the different generational, tendencies. There are staff that are taking care of elderly families at home, family members, struggling with family members that have lost their job. So all of those things happen. We have staff working double time, triple time, working doubles, not getting much of a day off because they're doing all those other things at home. So just really pointing that out. And I know most of you know that, but they really are a great team. They really have put all boots on the ground and are gotten very resilient. I think the biggest thing has always been, mostly in the spring and a little, more so in the spring, but still in the winter with the surge too, is the fear of bringing COVID home. I think we've been so fortunate that this team has been very, very vigilant about infection control. That's been key with keeping this COVID at bay in the emergency department. We haven't had an outbreak here. We've kept ourselves safe. We keep our patients safe. You can go to the next slide. And then you'll see one of our nurses holding up, they did a hashtag stay home, but that stay home is really stay home away from, social large gatherings, really follow the Department of Health and CDC guidelines about not, having large parties or gatherings, wearing masks, staying 6 feet away. We do not want you to stay home if you're ill. We are very proud to say that we're your safety net in this community. We are safe. Our staff practice safely. The hospital is clean. We have great, we've learned a lot. We've had a lot of lessons learned. We have processes in place to really protect one another and all of you. So we want to make sure that you know that it's okay to come to the hospital and not to wait. And I think Dr. Napoli touched on that earlier, but just going to keep reiterating that. So the winter came and we hit surge 2. Same challenges, testing, but we've learned a lot more. The antigen versus the PCR test quality. There's been a lot of improvements with the testing, not so quick to shut down elective care and surgery, return to work. There are very strict protocols for staff, really keeping, again, everybody safe. We had to look at PPE, went from paper masks and disposable items to, this is going to be around for a little while. And we're going to look at staying in this probably through the summer, if not into the fall of 2021. So looking at more non-disposable and things that can be personalized and used for personal protective equipment. Lifespan procured a lot of, we had a lot of, their different names, ENVOs, elastometric apparatus or PPE that we use. You can see, thank you, Dr. Napoli. He's kind of pointing out and circling they kind of look like spacesuits that you would wear to Mars, but we need to keep our staff safe so that we can keep you safe. But really ramping up the amount of supplies and the PPE has been great. As far as infection control, preventing spread is always a priority. And then vaccine distribution. I think a lot of people will have questions on that, but Dr. Napoli will be touching on that in a few more slides. We continue to separate and segregate our group in the winter. I will say that the spring was a lot easier because the weather was nice outside. We knew that if we had to continue to deal with COVID and inclement weather, that we would have a problem with the line waiting outside the emergency department, whether it's strong winds or rain. So we again changed our process and how we managed patients coming in. And so far, things have worked out and we do not have people waiting outside in inclement weather. I think there's a list there. You can see the elective medical care and maintaining available beds. That can be a challenge at times, making sure we put the patients in negative pressure areas and minimizing staff exposure, and then looking at criteria for utilizing FDA approved medications. Next slide. Staffing challenges continue in the winter with surge 2. Taking what we know and putting into action has been something that emergency department staff have done well. Ongoing issues continue. Quarantine. We're seeing the cases of COVID go up in Rhode Island, like Dr. Napoli pointed out. But again, we're testing a lot more. So every once in a while, it will hit a family member not related to work, but it puts them out. So it causes a staffing crisis, in the hospital and emergency department. But we've been able to overcome that with team members really step it up and cover for each other. So that's been great. Staff wellness, I can't say enough again about the staff that have to parent and homeschool at home and take care of elderly parents and just the stress of going to work and wondering, will everything be okay tomorrow, and hoping that things stay safe. There'll be more about vaccine distribution in a few more slides. Most of the staff have been vaccinated in the emergency department. I can safely say it's close to 100%. So most of the staff are getting their second vaccine either last week or in the next 10 days. Providing care again in the winter, that changed only because we learned a lot more. So we've adopted what we've learned. We're adapting care to this phase because we know from other organizations in the nation and from what we learned in the spring that we were able to, make changes that really work towards keeping the community safe and the staff safe. Research is key to continue staying on top of research, which we try to do at unit council meetings and through the Slack app. Dr. Napoli is going to be speaking more about medications and vaccine. And I'd be remiss if I didn't speak to the increasing need for acute mental health care in all of our emergency departments. And I think I could say that's pretty much a nationwide issue. It was a problem before COVID. And you can imagine people that have stressors in their lives or mental health issues, to add a pandemic to it has just really quadrupled, if not more, the number of patients that we've seen. So we'll continue to work on resources for that. So we're always looking for any innovative ideas on how to deal with that need for acute mental health care. And hopefully that will get better as time passes. Next slide, please. You notice Dr. Napoli didn't give me control of the slides.
It doesn't seem, it responds after like the 5th time I tap on it for some reason, but.
I think there was going to be a map next, but if that's coming, do you want me to do this slide?
I don't know where that went.
So we had for those of you that don't know, we did a very large, huge renovation, an ED transformation that was built on philanthropy, which we're ever so thankful for. We went from a 17-bed to a 30-bed emergency department with a trauma room. And, oh, there it is. And I can't say enough. I mean, it was just overwhelming to have such a beautiful emergency department. I mean, who would have thought that this pandemic would hit us just months after, closing on the books on that ED transformation? Looking back, would we have done things differently? Maybe a little bit, but, we've been able to have a workflow before and after COVID-19, as you can see here. Some things, additions that we did do that we had to kind of modify that. Going forward, if we could redesign another department, we'd probably add a little more of this, but we'll cross our fingers and hope that our children and our future generation doesn't have to deal with this pandemic for a long, long time, another pandemic. We have a decontamination room that was normally used for training for possible Ebola, for possible contamination of anthrax or some other very volatile poison. We use that daily now. We've converted it to be a room that we can do triage in for COVID patients. Negative pressure rooms, we were able to add more negative pressure rooms to the emergency department. We were able to obtain multiple HEPA filters to add to the rooms. The department is being cleaned continuously, not just by our staff and ESD, but contract staff that are constantly cleaning everything and just making sure that the place is sanitary. And I will turn it over to Dr. Napoli, unless anyone has any questions about my section.
So what will be different about my experience? So someone asked this question in the chat. The wait time to wait to be seen has generally been about the same. Obviously that's kind of a priority. That is the suggestion that perhaps people are not coming because they expect to wait a long time to be seen is not actually the case. And some of that is a circumstance of the fact that the volume is down, and some of that's just been us adapting our workflow. So the time in the emergency department will typically be longer. Some of that's because our cleaning procedures are more detailed. Some of that's because the patients coming to the emergency department are of higher acuity and more complicated. And some of that's because simply as we identify patients that may have COVID, the tests themselves take a little while. If they're rapid tests for specific reasons, then the tests themselves can be the sort of bottleneck to movement and flow in the emergency department. So what you'll see is you saw pictures of our staff. Staff will greet you in partial PPE, meaning certainly when they greet you at the front, you will see someone in a mask and goggles. And then if you're a PUI, you'll see the full PPE that you saw some of the people in with the gown and gloves. And patients, when they arrive, this is a sort of a diagram of our ED had it sort of what it would look like and what it did look like pre-pandemic. You walked right up into an open triage area and there was a nurse waiting there. And this is post-pandemic. And what you see down here is this is kind of pre-triage. So when you arrive in the emergency department, you can see someone here who's going to essentially screen you for whether or not you have PUI, or if you're a PUI, whether or not you have potential COVID symptoms. And if you do, that changes the sort of workflow for your care. It doesn't change the wait time, doesn't change anything except for the way in which we manage where you flow within the emergency department. Other things that, unfortunately we've had to do, but for obviously good reason, there's no family waiting in the triage area. There's no family waiting in the waiting area, which is people recognize is probably over here. And there's no visitors, and all of that is largely because we want to reduce the potential for an individual to spread COVID within the emergency department to a family member, to someone they're unassociated with. And so unfortunately, we've had to adopt that process, which actually, in fact, all hospitals in the state and pretty much nationwide have adopted. So that individual who comes in here and is pre-screened and is a PUI is largely either going to go into a separate part of the ED. And this is what I just drew in the box there is what the size of the old emergency department basically was this area. This area here in a circle is the new space that we sort of moved into. So the ED doubled in size. In some ways, fortuitously, when the pandemic started, we were able to essentially, this is where the PUIs are going, and this is where the non-PUIs are going. And so we're able to adapt the workflow so that if someone screens positive, they would either go directly to a bed, or some of you, if you've ever been to the emergency department lately, would go here, triage in the decon area, and then into a bed. And so we've been able to essentially sort people such that upon arrival to the emergency department, if you are at risk or deemed to be at risk of COVID, then we immediately sort you away from, or if you're someone who's not at risk for COVID, we sort you away from the people that may be at risk. Now, once you get into these beds, you are obviously separated from the rest of the patients, and a lot of these rooms are negative pressure rooms or have HEPA filters. So the room itself is effectively your own self-contained breathing area, if you will. So I know we're running a little bit long, so I wanted to touch upon this, and we wanted to make sure to give people ample opportunity to ask questions. So to go through the treatment, so the main treatment, as everybody knows, is oxygen. It's clinically proven to be effective, as most people would not be surprised, but this is primarily our major treatment for patients who have COVID, because many patients go on to have COVID pneumonia. Those patients that get admitted to the hospital are frequently there because of COVID pneumonia. And that's basically like a viral pneumonia infecting your airways and reducing your ability to oxygenate. And therefore, you see some patients that are showing up hypoxic, going to the ICUs, needing enhanced ventilation. And obviously, the oxygen is the key to treatment. I have in here a pulse oximeter because we as providers have started to recommend to people at risk of decompensation from COVID, and those would be, heart, lung, obesity, diabetes, the things that come to mind, perhaps elderly patients in and of itself. The pulse oximeter is something that you can get for $20 to $40 either online or at your local pharmacy, and something that's a good monitoring for any kind of decrease in oxygen level. So that's become a strategy as well for the patients that are discharged. The other only sort of routinely known, clinically proven treatment in COVID thus far has been steroids, and particularly this is dexamethasone, although all steroids are effective. And studies have shown that a 10-day course of Decadron improves the outcome of patients, and in fact lowers the death rate of patients that are sick with COVID. So anybody requiring oxygen who comes into the emergency department, and again, just to be specific, it's just those people requiring oxygen, not if you show up to the emergency department, we test you and you have COVID, that do you get steroids. It's only been in those people that are more than moderate to high risk, or moderately or acutely ill patients, that steroids are indicated for, and they have a substantial impact. Patients that are coming into the hospital are generally getting Remdesivir. That was something that was gotten emergency use authorization. It inhibits what we call viral RNA polymerase. This is the virus' ability to actually make copies of itself by using your own cells. And that was studied on an emergency use basis. Early on, it was thought that it would have a significant impact. The WHO now actually does not necessarily recommend it, but there's no real evidence of harm. And there's some suggestion that it may speed recovery. So it's being made available throughout the United States. It's being used in lifespan in many of the admitted patients, and is available throughout the lifespan affiliates, including Newport. And again, I should say that's not something you would be seen in the emergency department and discharged with some doses of. This is an IV medication for those patients sick enough to be admitted. Other things people have heard, particularly in the news lately, the monoclonal antibodies. These are antibodies directed specifically against the virus. There are 2 of them available. Regeneron is what President Trump got, and then Remdesivir is an antibody developed directly from a COVID-19 survivor and then sort of made in mass quantity. And this is the idea basically that you're going to take other people's antibodies and administer them to someone who's sick with COVID, and that this would reduce the likelihood of a bad outcome. Unfortunately, there is no proven clinical benefit to date, other than perhaps reducing the viral load and perhaps reducing the likelihood of admission to the hospital. But these are very early studies, and despite claims by some in the press that this is in fact the thing that fixed someone or what have you, there's no clinical proof that that is really the silver bullet for COVID. These 2 are offered at lifespan. They're not offered on an emergency basis because they're not necessarily studied in that way, but certain individuals who meet criteria for them can get treated. Your primary care doctor, particularly in those of you that may be concerned or questioning, can refer you to the lifespan affiliates, particularly Miriam and Rhode Island, where there's essentially a clinic for IV administration of these for those people who meet criteria. And in this case, I would say that your primary care doctor, if you're one of those people that is positive, can be the one to refer you and identify whether or not you're a candidate. Convalescent plasma is one of the last things that you'll see in terms of treatment of the acutely ill patients. And basically what this is, and this graph or this figure basically shows it, is the equivalent of the blood transfusion for someone who's having a gastrointestinal bleed. Well, they're taking the plasma from somebody's blood and the antibodies that are in it, and then directly sort of infusing it into another individual. It's basically like a transfusion. This has often been discussed in SARS and Ebola. Unfortunately, even though it's been studied multiple times, it has not really been proven to be effective. Right now, it's only available in a research capacity, and there's been 3 negative international trials, but trying to find what seemingly would be something that clearly has reason to work, finding which patients it would work in. What does not work? Azithromycin, and the last 3 I would specifically note: chloroquine, chloroquine phosphate, and hydroxychloroquine. This one, as many of you may have seen, was highly touted in the press, particularly by the administration. The president, I believe, took this preemptively or prophylactically. He had stated prior to getting sick. There is no evidence, and in fact, trials, when there was originally some statement about there being progress and that this would be a medication that would work, subsequent trials have shown that there is no efficacy whatsoever of that medication that we know of. So vaccines, there are different types, there are different effectiveness, and I'm sure there's a lot of questions of who's getting them when and how do we find out how to get them. I will tell you up front that we are not the purveyors, if you will, of the vaccines. We are not the deciders as to who gets them, we being emergency physicians, providers at Newport Hospital or Newport Hospital as a whole. This is, I think Dr. Gaines kind of phrased it nicely, as sort of a top-down approach. That's the Department of Health that is deciding the priorities based upon recommendations that actually come from the CDC. And then as the vaccines are getting emergency use authorization and then being made available and then being distributed to the individual states, the Department of Health, the state basically is then distributing it from there. What you've seen in the news lately, obviously, is these 2 vaccines, Moderna and Pfizer. Pfizer was the first one Moderna was the second one. We've received both of those at Newport Hospital. I actually received the Pfizer vaccine and just the other day got the second dose. These are being distributed. The first line of people getting these are the healthcare providers at risk with patient-facing activities. Obviously, emergency department personnel are pretty much 100% vaccinated as of now and now getting their second doses, as I just did. And then skilled nursing facilities. And the rollout there has been a little bit slower than it has at hospitals for various reasons. These medications, and I should note, because someone's probably going to ask, they are pretty much only available in certain select settings because they require negative 90-degree freezers. And I specifically note that not to get too much into the details, but because you have to have a facility that actually has the ability to keep these frozen, because once you thaw them, if you will, and then prepare them, you only have about 6 hours before the vaccine itself is effectively something you need to throw out. So this takes, and the people that have been involved in this, this takes a lot of skill in ensuring that there is no wasted vaccine, making sure we schedule people, make sure every dose that's available is given. And that's been a rollout that's occurred over the last couple of weeks, essentially since around December 15th, December 14th, at all of the Lifespan affiliates and other affiliates, and it's gone extremely well by those people that had organized it throughout our system. And I think we're near through Lifespan around 6,000 people vaccinated, and so that's been successful in that right. Coming down the line next is believed to be basically AstraZeneca and Oxford and Janssen, which is actually a lot of people are referring us to the J&J vaccines. These vaccines, Moderna and Pfizer, are believed to be 95% effective. And on the left here, you see a graph of somebody that gets the vaccine. Let's say that was me, for example, on time 0. If I got the placebo, I'd be in red. And if I got the vaccine, I'd be in blue. And this is my risk of getting infected with COVID on the graph here. And obviously you see right around the 7 to 10 day mark, my risk basically levels off such that I'm protected. And then there's a second dose that goes along with the dosing regimen. So the incidence of infection is quite low once you get beyond the 10 days. And so that's obviously been, as I said at one point, literally and figuratively a shot in the arm for staff who are looking at caring for patients throughout the rest of the winter to know that there's a good chance there's a highly effective vaccine. Of comparison, influenza vaccines are often in the 50 to 60% effective level. So this is particularly remarkable. And the mRNA vaccines, Moderna and Pfizer, are new. This is the first time that type of vaccine technology has been used, and thus far obviously quite successful. The common reactions to these, and the second dose is you're more likely to see this than the first dose. The obvious thing is that there's tenderness at the vaccine site, that people get fatigue, headaches, chills and fevers, muscle pains and joint pains. And I'll say just specifically for myself, I got these two after the first vaccine, and I got all of these from the second vaccine. Not to scare anybody, but I would say that in my view, most of the colleagues I talked to got mainly just perhaps tenderness and fatigue at most. And generally it begins around 6 to 12 hours, the symptoms, and lasts less than 24 hours in both cases for myself. And so if and when you get your vaccine, particularly if it's Moderna or Pfizer, the only thing I would say is not to be particularly worried about these. These symptoms were not severe, but they were there. And generally speaking, they go away in 24 hours. There is a lot of lay press news about people getting allergic reactions to this vaccine. That is extremely uncommon. The CDC, I'm not sure it's this low, but I think the CDC put it at like 11 in a million or something like that, some really low number. So it's quite uncommon, and it's believed to be more common in those individuals who have had a allergic reaction in the past. So when I say allergic reaction, like required an EpiPen and had to come to the emergency department. So one of the clear questions that's probably out there is, when am I getting mine? And so you see the rollout here that started on December 14th. Like I said, it was basically hospital staff, EMS, home and health hospice workers, and then skilled nursing facilities, and then moving on to other staff that are in patient-facing activities, and then particularly here, that's probably of note is the next group is persons age 65 and older. So we're still in this phase, sort of unfortunately or not. People, if you've been reading in the late press, have seen that there's been some criticism of a slow rollout of Operation Warp Speed. There was a lot of anticipation of the Pfizer and Moderna vaccines, and in fact, we did get these in the state, and then sort of a slow up of disbursement after that. We're hopeful that more will come in short order. The vaccines, as I mentioned, for the hospital staff are occurring at the hospital site, for long-term care facilities or at the long-term care facilities. And then for everybody else, there's discussion as to where that's going to occur, and that's going to be state specific. In our state right now, it's unclear, but if you've seen in the news recently, the Trump administration has said at least that they're going to speed up the plan to deliver the COVID shots, and that they're actually contracted already. But whether or not this occurs is to work specifically with pharmacies throughout the country, and we're talking Walmart, Rite Aid, what have you, to disperse the vaccine. Again, it's a top-down approach, that meaning that we, the hospitals, are happy to be involved in it, but are not particularly controlling who gets the vaccine. It's not coming to our facilities to disperse it to beyond the healthcare workers. And so we're waiting word from the state when they get vaccine and how they're going to do it. The timeline that is estimated is phase 1, as I put up there earlier, is December to February. Phase 2, February to April. So this would be sort of in the February area. You're starting to see the phase 1B, if you will, people that are essential workers but not healthcare workers, people that are age greater than 75 and then age greater than 65 would be in this area or in this area. And then the general sort of healthier population, probably not until April and June. That's what's at least being said at the current moment. I would say that, as I mentioned earlier, what's being criticized lately is we got to December, and there's been a lull since that time. So hopefully it will pick up. If you have any questions, these are obviously good things, good resources here. covid.ri.gov, that if you go there, that's the ability to schedule an asymptomatic test. It's very smooth, very easy. As I've mentioned, I've been tested a couple of times. Asymptomatic test, and you stay in your car. It does not hurt. Results are back. You get a text message basically to log in and find your results out. There's some COVID vaccine information if you wanted to go to one resource. It's c19vaccineri.org. That should probably be the best one for you finding out the latest on vaccine information, or just going to the Rhode Island Department of Health. So with that being said, I will pause. I will let's see here, check the chat screen. And then I don't know if there's a way to open it up to people to ask questions. I defer.
Yeah, if certain people have questions, if you type them into the question and answer chat, if you have a complicated question, there is a way I think that I can allow you to speak. So we can certainly do that. One question that came in from Irene Graham that says, on the screen of people 65 and getting vaccine, there was a question of whether that was just incarcerated people in that category. I don't know if you have a way to go back to your prioritization scheme slide that had.
Yeah, and I think it's it's kind of clumsy, I guess, the way it's written, I suppose. But yeah, it looks like it says high risk incarcerated persons and then gives you what's high risk. But what's been identified as high risk in and of itself is persons particularly age greater than 75, but certainly age greater than 65. So it's not been made clear, like at least to me and to my view of a website yet, how what the priorities will be within this sort of phase of people. I know that we have seen, and you've probably read in the news, specific high-risk populations have been targeted, incarcerated individuals where there was a big outbreak, Central Falls, where there's perhaps the highest density per capita of people getting infected. But other states have specifically stated that age greater than 65 or 75 is a high-risk group, and they would be sort of the next people in line, as I expect would be the case in our state as well.
Yeah, I think that makes sense. And I think what you're showing here, you can see is kind of the top of a much larger prioritization scheme. This is really focusing on the highest risk individuals, and it gets down quite a bit deeper into all the different categories. And one thing I'll add is if you combine both the Pfizer and the Moderna vaccine, I think hot off the presses that we passed the 9,000 mark. If you combine both of them together within lifespan, and the fact that we were able to give those out within just a couple of weeks. I just wanted to point out that Dr. Napoli's comments about the side effects. We weren't really sure when we started rolling them out how significant that would be. And we were concerned because at every lifespan facility, of course, we're screening, as was mentioned, for all these COVID symptoms. And so we were afraid if we gave everybody in the whole institution the vaccine all on the same day, then if the following day or the day after that, if everybody was screening positive for these symptoms, then we wouldn't have anybody left to work. So we did roll it out in a little bit of a staggered way, but also wanted to make it convenient for staff and scheduling and things as well. So despite the attempt to try to stagger it so that we still had people that were able to work if they had side effects, fortunately, the side effects were mild, as Dr. Napoli mentioned, but we were able to vaccinate almost the entire patient-facing staff of lifespan within a couple of weeks, and now we're getting the second doses. So it's pretty remarkable. But also would just echo what you said, which is that unfortunately there's trackers and things you can look online to see where the vaccines are going to the different states. And Rhode Island sort of falls really within the top quartile of states in terms of per 100,000 people. I think the most recent numbers I saw were somewhere between 2,000 and 3,000 doses per 100,000 people. And that's obviously just looking at healthcare workers in the highest risk population. So we're anxiously awaiting more vaccine. Certainly, if we're called upon to help administer it, we're happy to do so. We're doing as fast as we can to get our healthcare workers vaccinated as much as possible as well. But eager to make that happen, and we're certainly also eager to coordinate with other resources to vaccinate as many people in the community as possible. So more to come on that. And George Petrovis, I know your number. I will definitely connect with you. Maybe we'll pick a time tomorrow to chat because you have some great suggestions and I'd love to hear more about them. Definitely want to open it up if folks have other questions. And I did want to mention Loriana, just a huge thank you from her and from myself and this whole group is just the community support, not just, the meals and all of the support through the pandemic, but the John A. and Hope H. Van Beuren family and all of those that donated to the emergency department capital campaign and made that renovation possible. Couldn't have been more timely as it turned out. So really remarkable. There was a question about the slides and information being listed in Spanish, and can the hospital do something similar to this in Spanish? That's a good question. I can certainly find out if there's an ability to translate some of the key slides, so we can certainly work offline on that. And then Susanna Kopp asked, what is the most recent quarantine time frame for patients that are COVID positive and COVID negative? Do either one of you want to jump on that one, or I can tell what I know as well.
Sure. I believe, I'd have to check, it changes, but COVID positive is either 10 to 14 days. And COVID negative, you're better off there are options, if you will. And I'm not sure what exactly is being asked of COVID negative, but if you're COVID negative in quarantine because of an exposure, for example, in some ways there are options, meaning like you could quarantine for 14 days, or you can quarantine for 7 days if you get a test at 5 days and it's negative. So those kind of questions, the easiest thing to do, which I've done because it actually changes day to day. I shouldn't say day to day. It's been evolving over time, and the time has actually gotten a little bit shorter, partly because we know a lot more, but the time has actually gotten a little bit shorter, and now we have testing availability, and we've layered testing into the normal quarantine period estimations such that particularly COVID negative patients can get tested, and or if you have a test negative at 7 days, I believe you can come off quarantine.
Yeah, I definitely check the CDC websites for these guidelines all the time because they change frequently. At one point, if you were exposed to somebody COVID positive, you would assume the COVID positive family member would potentially be infectious for 10 days, and then your quarantine wouldn't start until day 10, and then you would add 14 days onto that. So at one point, you were out for almost a whole month. Fortunately, with testing and some other tricks and new knowledge, we've been able to shorten that up. But that I understand is exactly the sort of in the 7 to 10 days, depending on your immune system and your individual's kind of conditions. And then the quarantine, really, for the most part, is with or without testing is variable, but it's definitely still significant. And so you can imagine within the hospital on staffing, nurses, all the support staff, physicians, you name it, anybody that gets exposed, or of course, if they test positive, we definitely have a significant number of people that are out or being quarantined at any given time. So it makes some staffing challenges, and that's not unique to healthcare. Edna asked a question: if you're a dentist or someone who falls in the last category and you're 65 years old, would you get the vaccine for 65-year-olds, or do you wait until the group who have dentists? My understanding, and correct me if I'm wrong if you know differently, is that whichever category you fall into, which puts you in the highest category, is the one that you would get. So even though I'm younger than 65, because I'm a healthcare worker, then I fall in that highest category. So I think whichever category is the highest for you trumps all the other categories. So in that case, a dentist or healthcare worker would trump the age, in my opinion. Okay. Well, I know we're a little over, and I really appreciate everybody and their engagement and their questions and things. It looks like Elizabeth Huerta put in a resource, so I'm going to make a note of that, which is great. Thank you for the resource from the Spanish-speaking community. So I think that's fantastic, because we certainly want to be able to open this up to as many people as possible. And each one of these events we've had, the number of people that have been able to participate has grown. So this is really turning into a great opportunity for us to get out and get the message out to the community and to be able to get questions answered that people have. So just another huge thank you to Lisa and to Anthony for taking the time and putting this presentation together, for all your hard work in the emergency department, for keeping the staff safe, for keeping the patients safe, and for treating often critically ill patients and just being there for us 24/7. So a huge thank you to you and to the emergency department staff. And then a huge thank you to the attendees that took the time out of their evening to listen to us talk and to ask questions. We really appreciate this. Looking forward to our next event in February. I'm working with Dr. Weiss about a cardiology topic. At some point, I'm going to try to get one of our hospital medicine doctors to talk about what's life like once you get admitted to the hospital with COVID. They're a little bit overwhelmed right at the moment, just with the hospital being to capacity. So a little tricky for them to put together a presentation. So I'm going to give them time to let me know when they're ready. But in the next couple of months, look forward to some cardiovascular health as we get into the spring. Look forward to the hospitalists presenting, and then we have a whole nother lineup over the next few months as well. So much more to come on the community lecture series. Thank you, everybody. Anthony, Lisa, any final words you guys want to say before we sign off?
No, thank you all for joining. It was great. Look forward to doing it again.
Awesome.
Thank you very much, everybody. I would say to keep your attention on the Rhode Island Department of Health website. I'm sure probably the most interest is revolving around the vaccine, and I would imagine the website itself would be your best and quickest resource related to that. So again, thank you all for tuning in.
Hope everybody can get the vaccine really soon, and hope everybody can stay healthy and stay safe. Wear your masks, wash your hands, stay in your little pods, stay home unless you're sick and you need to come to the hospital, in which case come see us. We're ready. You won't have to wait forever. We'll get you in as fast as we can, and we'll get you taken care of.
Right. Thank you.
Thanks so much, everybody. Have a good night.